Distinguished participants, I will try to provide you an updated information related to brain stimulation treatment. In order to increase the effects, in order to shorten the treatment time, what can we do? And there are certain new procedures, and also I will talk about the Stanford protocol. And this is an important protocol, and also dorsomedial frontal cortex stimulation. We have got an experience about this. I will be elaborating on this. And psychiatric disorders, so the resistance rates are very high. So the patients who are not responding to single dose treatment is about 30-40%. So there is a need for the new treatments. So non-invasive stimulation treatments are actually related in psychiatry. In 1938, after ECT, after 60 years, we have started with the TMS. And what are the reasons for the being too late? One of them is that is in the ECT, the patients are actually have to have a problem, just like epilepsy, for example. And in order to act for this, they first have to have an attack, a fit. And we know that TMS can be applied without any problem, and also there are the right transcranial right flow stimulation, alternative flow stimulation. And if we go for the efficiency analysis on the right side, as you see here, the efficacy, this is a TMS. So in terms of the efficacy, there is no problem. And if we just make a comparison with sham, it's here we have an efficacy is about 80%. And transcranial, the flow stimulation is found to be very low. It's a result of a meta-analysis. So for that reason, here I will try to weigh on the TMS. TMS it means that it's an electrical environment that is created, and it stimulates the brain. And we just test the affective, cognitive, and perceptual fields. And in psychiatry, in order to manipulate and also compensate the processes, and of course there are variable. So when we look into the motor parts, we see that there are great differences, and it is also seen in the treatments as well. In the treatment, the optimum treatment is still not known. Which stimulations are to be tried? What are the targets? These are still are debatable. And in TMS, we see that the cortical structures are stimulated. In terms of the depth, the 8 coil. So the coil, it goes deep about 2 or 3 centimeters, and there are 2 other more coil systems. One of these double cone, and the other one is edge coil. It goes into deep by 5 or 6 centimeters magnetic magnetic stimulation. FDA approved the treatments are in 2008, and obsessive compulsive disorder is 2013, and then in 2021 anxious depression, and in 2023 we have Saint protocol. We'll elaborate on this, and this was approved. And for the adult psychiatrists in 2024, just a few weeks ago, for the adolescents, it was approved for the adolescents above 15 years old. If we look into the literatures, it talks about the CE certificates. These are really more Alzheimer's disease, autism, and bipolar disorders. And actually, these are to be accepted as safety protocols. It shows the safety. And in many of the diseases, just for trials. They can be used in a trial method, and it is safe to use. And when we look into the expert views, and we see that the level of the proof is in the major depression. It means that it is certainly efficacious, and and in the B level, it's in the schizophrenia, for example, and in the other diseases, it may be efficacious. And we see that hallucinations and addiction, audio hallucinations. And how shall we select the patients? It is possible that it is said that we may go for TMS if a patient does not respond to a single drug. It could be if there is psychotic depression or suicidality. ECT is better, so they should not be referred to TMS. And in the treatment, within 6 weeks, it may be enough, but in some patients, it may exceed 6 weeks. And in the patients who respond to TMS, of course, TMS would be opted more. And also the contraindications, these are not very much problems. Epilepsy episode and the general mood disorder, and pregnancy is a question mark, and the structural lesions in the brain, and we just accept them to be relative contraindications. In terms of the adverse effects, side effects, headache, this is mainly tolerated, and we see that the fits are very low, and manic shift is not much in the pregnancy. The theoretical risk is that to have an fit, but in many of the cases it has been seen that TMS can be applied during pregnancy, and whether we should go for the change in the drug. If there's no complicated treatment, especially if we can just decrease the attack threshold, there's no need to make any change in the drug. TMS has a attack. It has got an effect that it goes through the distributed networks. So what you see in the network here is that the acute effects, TSM, neuronal, when they are applied on the dorsolateral, we see the neural activation patterns are seen here. And after a long session of TMS in the brain, if we measure the connectivities or the changes in connectivities, then we still have the same pattern. So the acute effects may precede or may predict the flows here. So we see that dorsolateral prefrontal cortex is used. It is just acts like a center. Many of the networks go through this. The salience network here, default mode network, and central executive network are also present here. They operate as an hub here. And why it is so? It is just because it is easier to access here, and orbitofrontal part are rather hard to access. They are rather deep structures. After TMS application, what happens? What happens that there is a function normalization. For example, dorsolateral prefrontal cortex, the global connectivity increases, and also there is an increase in the adverse connection with the amygdala, and dorsolateral part starts supervising the lower structures. We don't see this in the sham method. And when we make a comparison ECT with TMS, what it changes in 2023, there is a study which is a leading study. After the right part stimulation, there's an increase in the volume, which is seen in the ECT, especially the hippocampus, amygdala structures. You see that it is rather localized on the right side, and this volume increase could not be shown in the TMS, or it is rather considered to be lower when we make a comparison with the ECT. And in the TMC, the synaptic or neural effects are macroplastic or mesoplastic in the synaptoglysis, synaptogenes or neurogenes effects are caused. And in TMS applications, there are important studies, and one of them is, as you see, in 2008 it was carried out, and then with the with FDA requests, an optimization study was carried out. Accordingly, response and remission rates are lower than 20%. However, in 2018, within the 3D study, the response and remission rates are about 40 and about 30 remission rate. And in recent years, in the accelerated TMS studies, these are just similar to 3D. So the accelerated method objective is that the doses to be given within 1 and 2 weeks, and it is about it is carried out or applied 2 to 10 sessions in a day. And in depression, it was the NNT was found to be 5.4 and RR is 3. So we see that there's a treatment which has a mid-size efficacy, and what we see that the response is about 40 to 60%, and the remission is 18 to 50%. But in many of the studies, it actually states to be 30. So this is the data that we have in hand. And in the resistant depressions, the TMS and ECT compared, and we see that the response in ECT is more than 1.5 fold, and it is also valid for remission. But in TMS studies, the psychotic depression patients are not allowed into this, and the psychotic depression patients, this difference could be more in this regard. In obsessive compulsive disorder, OCT, we see that OCD, we see that there is deep TMS carried on. And we see that in the depression, in the obsessive compulsive disorder, it was found not to be effective. So this is a result of the OCD, and here 43% of them there's a response as per the OCD scale. So what are the results? What are the aspects affecting the results? As the number of the sessions increase, it is affected, but the age is actually is as the resistance increases, the TMS response decreases. And the dorsolateral prefrontal cortex, when we make the stimulation, if it is correlated with this stimulate, then there is more efficacy. So for what do we do for the optimization? One of these accelerated TMS. It is to be done 3 or 10 times in a day. The objective is to increase efficacy and to shorten the treatment. And the meta-analysis show that the accelerated TMS helps the improvement of the depression scores, and this is not different than the standard TMS. What is good for the accelerated TMS? It actually makes the people recover in a short period of time. And the coils are one of the optimization trials. What can be done? So we have the 8 form coils and also H type coils, and this is a new study. It shows that in the H1 coil, the response and remission rates are rather high. However, while the responses are more, the remission rates are not found to be significant. Perhaps it is due to the number of the participants. But in the deep TMS is more found to be more effective though. And in one of the optimization trials, it is a theta burst. So it is very fast, within 3 minutes. Normally the session goes for 40 minutes, but this can be compensated with this one. Theta burst actually shows that it is equal to the standard treatment. So theta burst can be applied very easily with a comfort, but the advantage is that the costs are lowered and the patients can tolerate it. And optimization trials is actually to find the right target or right candidate, because we do not take into consideration the symptom changes. Some of them have got anxieties and some have got anhedonia. So in people, for example, dorsolateral prefrontal cortex, accessing to them may differ in terms of the individual differences, and these also differ in terms of anatomy. We can talk about 1 or 2 centimeters of differences in different people. So there are 2 fundamental methods used standard way. 5.5 centimeter method. So it means that just taking it from the motor field to the front to 5.5, and so also we have beam F3 system, and this is considered to be more appropriate in terms of anatomy, but in terms of the response to the treatment there is no difference, which is shown by a new study. And for personalization, for precision, dorsolateral prefrontal cortex, any field in this part, subgenial anticorrelation is shown with the cingulate part, because with this part the deep brain structures can be engaged into the treatment, and the studies show that the more the stimulated field is closer to the here, the efficacy is more, and subgenual cingulate functions as a hub, and there are many networks with the inner and deeper structures, and it has got a close connection with the dorsolateral prefrontal cortex. So Stanford study is related to this method, and as per the field that we identify with the standard method, these fields are rather more lateral and posterior. And the most important thing about the method is that theta burst treatment is given in a day, being 30 sessions, and this treatment to last for 40 days is given just in 1 day. And so it means that it is 150 TMS sessions. At the end of the 5th day, So 85 of the patients they respond, and remission is about 78%, and this is really a high rate. And in their effect or the efficacy, we see that it goes for about 4 weeks, and there are replication studies which are ongoing in this regard. And this is a last study which uses the same method. So it does not provide 30 sessions, only gives one theta burst, but local in terms of localization, it uses the Stanford method, and it is seen that it is not more efficacious than the standard treatment. So what we recall is that whether it is more efficacious to have it applied 30 times in a day, as it is in the Stanford protocol. So there are also alternative structures, or so the lateral structures, frontal pole insula, these are the centers that can be stimulated, but there is a need for deeper TSM, but sometimes they may give ache. The orbitofrontal parts have got more muscles, so that the patients may not tolerate it easily, as there would be an ache problem. And dorsomedial prefrontal cortex is the part that we stimulate. We know that in depression these are lagging behind. So it's an important center. This is a rather deeper structure, and when you stimulate, it is maybe the case that you are also stimulating that anterior cingulate as well. In our center, there are two methods that were applied. One of them is superficial, one of them is the theta burst, and the other one is deep bilateral dorsomedial prefrontal cortex stimulation. And in both of them, they are in mid resistance. They have mid resistance, and the response rate is that 47 with the deep one, and the other one with the standard one is 32%, and remission is about 30%. However, in the superficial ones, the standard ones, it is less. In the old method, the remission is lower. So this center may be an alternative for alternative. And in another study, in the dorsolateral patients who do not respond this, and the mid-lateral cortex is stimulated, and they could achieve 24 to 31% of remission. And also, in terms, we should focus on the symptoms. For example, the patients with severe anxiety, the medial structures could be stimulated. With the anhedonia, the dorsal lateral prefrontal cortexes can be stimulated. For X, for example, somatosensory cortex is stimulated. And for the addiction treatments, insula seems to be better, and for mania, there are not many experiences and proofs for that. And optimization trials, one of the optimization trials, it is the closed circuit. So as I'm shown before, the online acute effects, if they can predict the chronic effects, then if we intervene them by following them online, whether we can increase the long-term effect. Actually, this is a method that can be done. It has not been tried yet, but if it is in use, I believe that there would be high success rates. And finally, the time of application. And Dr. Greenshaw has mentioned, for example, simultaneous psychotherapy and exposure treatment, or during TMS, different assignments can be assigned, and accordingly, different networks can be activated. And during this time, TMS can be applied, whether the efficacy can be increased. Hypothetically, it can be increased, but this needs testing, of course. And EEG is important. And with synchronization with EEG, with TMS, which is synchronized with EEG, when it is synchronized with alpha rhythm, then when alpha rhythm is given in a certain age or in a certain period, the efficacy can be increased. So it is shown that this can be applied. There's also a hypothesis that the effects can be increased. As a result, there are many treatment parameters in TMS, and there are many studies required, and there's a long term in order to find the most efficacious treatment. And new treatments give good outcomes, and acceleration the treatment procedures, and taking into consideration the personal traits, the successes may be better. And just like in Stanford protocol, we may got good results. Thank you very much for this comprehensive and good